Otherwise, we'll get started. Perfect. If you want to go to the next slide, I'll give you guys a preview of what we're going to go over today. I'm going to, of course, introduce you. We have a new program manager for our quality improvement programs. So we're going to give you guys a quick intro for her. We are going to touch on quality improvement. You know, we do this every single coaching call. And so we're going to give a little QI update. We are very excited to have our data analyst, Gretchen, with us to share back some of your Q2 data, our cohort Q2 data, just so that we get a temperature check on how we're doing. Carly Swenson is going to give us an update on some upcoming trainings that we think are super relevant to you and for your nursing staff at your facilities. We have a case study that the Lutheran team is going to share with us so we can learn from their wins. And then finally, we're going to give you a little update on some perinatal health data that's coming out of the Colorado Department of Public Health, because I think it's super relevant to the things that we're talking about today. And then hopefully at the end, we'll have some time for some Q&A. Pretty informal. If you want to chat any questions in while we're going through any of this, please come off mic if you have questions. We'd love to dialogue about anything you all want to dialogue about as we move forward. So we will go ahead to the next slide. And I'm going to show you a lovely new face who joined our team just this week. So Sarah will come back next month and give you guys a more thorough introduction and share sort of where she came from and what she's doing with our team. But I at least wanted to show her face and her name. You'll probably start to see Sarah on emails and correspondence. So do not mute her in your inbox if you see stuff coming from her name. Welcome her into your inbox. Again, she's our new program manager. She's fulfilling what a lot of the duties that Elena had prior. And so we're very excited to welcome her to the team. If you want to give her a hi or a hello in the comments, go ahead and do that. All right, go to the next slide. And so any coaching call would not be complete unless we at least touched a little bit on quality improvement. And just as a reminder, we do this because COAIM-SUD is at its heart a quality improvement program. And we've spent the past 8 months walking through some of just the very basic steps of quality improvement. And to do that, we've used the Institute of Healthcare Improvement's model for improvement, which you can see here on the left side of the screen. We've spent time walking through the top 3 questions that we ask whenever we're planning and executing a really high quality improvement project. We've also talked through what we mean when we say plan, do, study, act, and what those cycles look like in our programs. So for today, what we're really going to focus on is this middle question at the top here, which is how do we know that a change is an improvement? And we talked last session about what measures we use for change improvement. We talked about process measures, structure measures, outcome measures, and balancing measures. If you want more information, that is recorded in our YouTube channel. You're welcome to go back and listen to that. But to just go one layer deeper today, we're going to actually look at the data that we're using from our measure collection. And Gretchen's going to give us some more insight on how we interpret that data so that we can make sure that our changes are improvements and then make decisions on how we can make further improvements. So we'll go to the next slide here. I think it's important to bring it back to the value of data for those of you who aren't data geeks, like some of us on this call, Gretchen. I think it's really important for us to know that the data is really our guide in quality improvement. And without data, we're just a bunch of professionals with opinions on what we should or shouldn't be doing. And all of us have very subjective experiences in our professional lives that are going to guide our decisions. But for quality improvement, the goal is always to reduce variation. And that means to become less subjective in the care that we're giving, and hopefully then less variation in the outcomes that we have with patient care. And so I'm going to hand it over to Gretchen. I know many of you have corresponded with her in your inbox. The data dashboards that you are going to get later this week came from Gretchen. And so I think it's important that you get to know her face and hear directly from her. So Gretchen, I'll hand it over.
Thank you so much, Amber. And thank you everyone for attending. My name is Gretchen Scholes. I'm a new data analyst here with CPCQC. It is wonderful to put some names to faces and faces to names. Please, as you all know, I hope you know that you can always reach out to me with any questions, concerns, comments, any feedback. I know that As Amber mentioned, as a self-proclaimed data nerd, I love looking at the data, but I also recognize that if you're not looking at it every day, it definitely can be a bit overwhelming. So always happy to set up some calls if you want to just dive a little bit deeper. Sydney, if we could go to the next slide, please. So we'll go ahead and start here today with looking at sort of screening rates for substance use disorder, anxiety, depression, and social determinants of health. And this is just all of the data that I'll present today is over the past 5 quarters. So comparing Q2 of 2022 through this last quarter of Q2 23. As we can see here in this graph, we have a lot of variability in the screening rates from quarter to quarter. And I think a lot of that can really come from inconsistent data submission from hospitals, or recognizing that not all hospitals screen for all of these different categories here. I do want to point out, though, we have been doing okay. There's always room for improvement, as I'm sure everyone here on the call knows. We can see on this yellow line across the bottom that the social determinants of health seem to be struggling the most out of all of the 4 categories that are listed here. And so sort of maybe putting in the chat what you think or your hospital has done to sort of improve screening rates in terms of all of these categories, but also more specifically, if you guys have had some serious wins in terms of screening for social determinants of health, how you guys have gotten there. Can we go to the next slide, please? Great. So here we're taking a look at a deeper dive into the race and ethnicity categories that we collect. I know that we collect based on total that have been admitted, but then we also do a bit of a deeper dive in terms of the race and ethnicity categories for those who have been screened for substance use disorder. And so over the past 5 quarters, you can see there's been a lot of variability amongst what's been reported amongst the various race and ethnicity categories here. Again, I think this is largely due to sort of this inconsistent or potentially incomplete data submissions in terms of the race and ethnicity categories being pulled across those that have been screened for substance use disorder. We'll see here that we had pretty good rates going into Q3 2022, a slight increase from Q2 of 2022, a really nice big jump here in Q1 of this year. However, we saw that in this most recent quarter, there has really been quite a significant trend downwards into what has been reported in terms of race and ethnicity categories amongst those that have been screened. So again, I open the chat box to anyone who has had a really great success in terms of being able to consistently report these categories, recognizing that this is a cohort compilation of everything from the past 5 quarters, recognizing that not all of hospitals are submitting quarterly data, recognizing that sometimes it's not all 100% complete data. So just with that caveat in mind. We'll go to the next slide and take a little bit of a deeper dive. So this is just showing a slightly more granular view of the race and ethnicity categories from our lowest race and ethnicity categories being screened. That includes this sort of catch-all category of other races. Also includes at 28% on average of Asians screening rates. And then lowest is going to be amongst the Pacific Islander race and ethnicity category. Our highest performing or highest screened race and ethnicity categories fall among the Native American and Alaska Natives, as well as non-Hispanics. That also includes the white population as well. So here just kind of pointing out that there is significant variability, as you can see from these sharp spikes here. In Q1 of this year, also in Q4 of last year. Again, if you want to put some factors, some ideas of why you think or believe that some of these screening rates vary so much by race and ethnicity, that would be really greatly appreciated. This is a collaborative effort. Let's go to the next slide, please. And here we're going to look at those who've screened positive for substance use disorder. Again, this is highest amongst Hispanic population, Native American and Alaska Native, and then also this group of other, whether this is other and other races or not reported. I lumped those two together just to sort of see, because we weren't able to really disaggregate which category they would belong to in this respect. Again, I think that this comes back to sort of variability amongst screening by race and ethnicity. I think that it also very much depends on the largest populations that you all are serving in your hospitals in terms of race and ethnicity categories. So not really surprising here. What is kind of surprising is that Pacific Islander here is, in terms of screening positive, really came up with nothing in comparison with the other race and ethnicity categories here. Again, that could just be due to underreporting, or really that they aren't screening positive on any sort of large basis. Let's go ahead and move to the next one. Here's where I really like to dive in and see, comparing both the SUD hospital level forms and the patient level forms, recognizing that here we can kind of look at both of these and compare the screening positive rates amongst what is reported in the hospital level data, which is a much more, a larger view of the quarter, versus the more granular patient level forms that we get for all the patients that have screened positive. Here you'll see, again, a lot of variability amongst what has been reported as a positive substance use patient amongst the hospital level forms versus the number of patient level forms that we get from quarter to quarter. On average, we're getting much higher rates of positive substance use disorder patients amongst listed in the hospital level forms, and then really not getting a full complete view with the patient level forms of all of the patients that may have screened positive, which is based on the hospital level forms. Again, want to emphasize this, or I guess I can't emphasize this enough, this can be largely due to incomplete data submission or inconsistent data submission from quarter to quarter. Again, if we're getting 5 submissions or 10 submissions one quarter and then 20 the next, it's really going to change the data quite significantly. There's several theories that I've heard in some of the coaching calls and discussions that I've had with various data champions in terms of why the number of patient forms submitted really varies and is much lower than is what's reported amongst the hospital level data. This could be losing the patient level form, not completing the patient level form, or barriers or difficulties to submitting this patient level form, from carrying it through from delivery to postpartum can sometimes be a challenge, and then taking that and then uploading it into the REDCap can also sometimes be a bit of a challenge from what I've heard. So if there are, again, other barriers or things that you can think of that might help us to make this process a little bit easier, or help each other make this process a little bit easier, if you have any feedback that would help other teams possibly be able to submit more consistent data, especially amongst the patient level forms, it's always much appreciated, both for our team, but also for your fellow data champions. Moving on to the next slide. So here I wanted to take a look at some of the great clinical care practices that you all are doing. Really strong since starting to measure from Q2 of 2022, we had a really great momentum there. Continued dipping a little bit through Q4 of 2022, but really seeing a strong comeback as of this past quarter, which is really excellent. I want to commend you all on your efforts to be reporting all of those clinical care practices for those patients. Again, recognizing a little caveat here that much of these clinical care practices will sort of overlap for each of the patients in terms of counseling and scheduling a postpartum visit and so on and so forth. But just wanted to commend you all on the efforts of this uptick here. And I think we can really kind of come through in the next quarter to really improve the clinical care practices amongst the hospitals, but also reporting this data so that we can give you all the much deserved pat on the back that you guys are doing with this data. Again, I want to open up the chat to seeing if there's teams that have had a really great success in terms of consistency in their clinical care practices amongst patients, and again, reporting this on the forms that you all submit as well. And just for the last slide, our team discussed some potential data improvements for you all. So as of for this past quarter for Q2 of 2023, we had 6 out of 20 teams submit timely and complete data. This means that you submitted hospital level form and patient level forms on time and they were complete. We do give a bit of a grace period in terms of submitting. So please always don't ever fear about submitting late. Always just feel free to give me a heads up and say, you know, this past week was insane with work. I didn't have time to submit it. That's totally okay. I check the submissions regularly, so please just feel free to send me an email and let me know what's going on and when we might be able to expect that. So I don't want to deter that. I don't want to deter anyone from submitting data ever, whether it's late or on time. That's okay. Again, really kind of emphasizing the previous slides in terms of improving race and ethnicity data, especially amongst those who have been screened. I think I cannot emphasize how important that is, because then we're really able to do a much deeper dive into the analysis of what might be going on with some of the racial and ethnicity groups and where we might be able to be putting a little bit more impact and emphasis with our practices. Again, depression and anxiety screenings decreased a little bit. That's all to say, again, could be due to inconsistent data submission, but want to put an emphasis on potentially improving how we can improve some of those screening techniques. Also, social work improvement is always, always, always key. And then treatments among the clinical care practices are significantly increasing. So I want to commend you all on that as well. I'm going to turn it back over to Amber if you have any final thoughts, but I want to emphasize, please don't hesitate to reach out to me if you have questions, concerns, want to take another look at some of your data. And as Amber mentioned, we'll be sending out those dashboards this week. So keep an eye out for those. Thank you so much.
Thanks, Gretchen. Always good to hear from you. Actually, Sydney, we'll pause on that last slide. And for those of you who aren't following the chat, I encourage you to read back through because there's some good questions if you want to weigh in and some suggestions. We want to recognize that many of our facilities, sort of the gap here in fulfilling the clinical care, meaning are we doing the right things for patients who screen positive for substance use prior to leaving the hospital? Is that gap between getting the care forms from your nursing staff and to your case management or your social work staff. And a lot of that problem lies in especially the hospitals who don't have LDRPs or they have separate labor units from postpartum units, that a physical form has to then follow a patient from labor where they screened positive to postpartum where they need most of the clinical care prior to going home. And so again, we're always looking for suggestions on how you guys have navigated that. Some of our hospitals have used colored papers, colored clipboards. Some of our facilities have suggested adding a signature line for case management on the form. That way there's some sort of trigger to the nurses who are initiating the form that eventually it needs to lead to case management hands. But if there's something that you're doing currently that is working well, please let us know. We'd love to share that with our other facilities. And if you are ready to do a PDSA cycle or a quality improvement cycle on trialing out some of these ideas, right? Trialing out having a clipboard specific for positive substance use screens or having a signature line on your data collection form, we would be very happy to help you facilitate that. I think, the most important slide that Gretchen showed us is that clinical care slide. And Sydney, actually, if you wouldn't mind going back, I did want to highlight that although there is some variation, the line that we really, really want to focus on is are these patients actually getting or receiving or being counseled on treatment services? And those lines are increasing for us, right? And so the most important thing that we're addressing here is maternal mortality related to substance use. And the ability to get these patients treatment is absolutely key, especially while we have a captive audience during the birth admission. So I want to applaud you, all of the teams who submitted data to us this quarter, that we are super excited to see those clinical care trends going up. And we know that some of the more technical trends here, like are they able to see social work prior to discharge, might be happening, but just not being documented because of sort of the process of getting papers between units in the hospital. So again, chat in if you have suggestions. Chat in if you also are wanting to do a quality improvement cycle and trying out a new idea for getting those forms from labor to postpartum and into case management hands. Perfect. All right, now we can move forward. And I'm very happy to introduce Carly Swenson. She is one of our team members. She's doing some amazing work in the realm of stigma and bias. And I'm going to turn it over to her to share a good opportunity that's coming up.
Okay, perfect. Let's go to that next slide, Sydney. There we go. So we wanted to announce that in October, we're going to be launching a training for nurses, not necessarily nurse champions, for our co-MSED program, even though you are all more than welcome to attend. But this is really for the day-to-day labor and delivery unit nurses. And in our September coaching call, I'll go a little bit more in detail about some of the conclusions. You may have seen or spread to your units a survey that we administered in 2022 and 2023. And here, I just want to give you a few of the quotes that we got from nursing staff at your hospitals. So one respondent said, "I've witnessed this with my colleagues, and even in myself, when all you want to do is the bare minimum for these patients," that's in referral to patients with substance use, "and not want to get them the added support or help they may need or even deserve." That really kind of sums up the attitude we got from the nursing staff, unfortunately, about how them and their colleagues respond when pregnant patients do report a history of substance use. Another one I wanted you to see that has to do with management of these patients. So the nurse spoke to the patient in a short and condescending way. The nurse discussed her substance use issues in front of the patient's visitor, her mother, who is not aware of the patient's struggles with substances, causing significant issues between her and her mother. So this is kind of highlighting two of the facets that we found, one being how nurses treat these patients, but also we saw a lot of reports of HIPAA violations, of nurses talking about patients, specifically those with substance use, to their families or to their peers or in public spaces. And then some were more logistic. So we saw one that said, "I think at times we may not assist the mother in bonding if we think that the baby will be taken by CPS." Or we got other reports of not wanting or being able to provide pain management to these patients. So this is just kind of a brief overview of some of the responses we got. And if we can go forward one slide, Sydney. Like I mentioned, next month is when I'll go into detail of all the data we got, the other themes that were identified, and show you some other quotes that really tell you what the culture looks like on the units of the hospitals in Colorado. But the most important thing is, now that we know and we've quantified how the nursing staff treats these patients, we have an opportunity to intervene on it. And I feel like that's the most important thing. So we're releasing this bias. I didn't mention earlier, 64% of the nurses said that there's either a slight or significant negative impact on the nurse's attitude towards these patients. So this is the majority of your nurses responded saying that there's a negative impact. And so we are producing a training. It covers many topics: clinical care of these patients, whether that be pain management or referral to CPS and infant bonding, or how to care for patients with substance use disorder clinically. It also has social determinants of health. So really emphasizing how these patients got to where they are and what we can do with them when they show up at labor and delivery. We're partnering both with the Maternal Overdose Matters, or the MOMS program, and an organization called Hard Beauty that has lived experience experts, which are people who had substance use disorders in their pregnancies, who then are willing to come speak about their experiences. And we'll have it where the nurses who attend can ask open and honest questions. I was on the call with the lived experience experts yesterday, and they're saying we don't tiptoe around issues. I want them to ask the questions, even if it might come off as rude. So this really gives them an opportunity to break down some of those stereotypes that they're holding. And also we're going to be doing examples of what can be done to intervene in a situation. So we might have people who want to do the best that they can, but then they're on the unit and they see other nurses breaking some of these barriers, whether it be the HIPAA violations or not providing adequate care, or whatever the situation is. We're going to be doing some examples of what you can do in that exact situation, which will help give the nurses on your unit the comfortability and the verbiage to actually spread these lessons through the unit instead of it just being within themselves. I will go ahead and throw the dates of the trainings in the chat. This is a pilot. We're capping them at 40. The registration will be released next month, but those are the dates just so you can be aware of them. We also have a one-pager that I can give to you that can be posted and spread around, and then another one will come out in September for the nurses themselves to register. But with that, happy to take any questions. Feel free to email me or send me a chat. And then I'll kick it back to Amber.
Actually, Carly, I'm going to kick it back to you because you get
Sure.
to talk about impact.
Oh, I do. Yes, yeah. I do. One more thing to announce. On a separate note, the Impact Behavioral Health Program that has been piloting in Colorado mostly focuses on postpartum care. But we have officially released our Impact BH toolkit. It is a resource guide. It is online. It's a website-based resource. You can follow that QR code and go to the link, or if you just search Impact BH and CPCQC on Google, you'll also be taken to the page with the link to our toolkit. This is a very comprehensive compilation of resources. It supports cross-sector partners in the assessment, planning, implementation, and measurement of behavioral health services, and supports systems and practice changes. Very comprehensive. It's designed for people in public health, in inpatient or outpatient care delivery settings or health systems, and also for community organizations. It's basically serving as a central hub to many of the resources that are available here in Colorado for your patients who do have substance use or behavioral health needs. So, also happy to take any questions about that.
Thanks, Carly. And for those of you who remember, just a couple of months ago, we had Jesse, one of our team members, sort of speak a little bit about our Impact Behavioral Health Care program and how it's really sort of the sister program to COIMSUD, in that COIMSUD does the inpatient care during the hospital birth admission, but we still know that these patients need excellent care as they transition back out into the community, and Impact Behavioral Health is one of the best toolkits that we have for making sure that the patients get really comprehensive, high quality care using the resources that are local to the community. And so while it might not be the most applicable for those of you who work inpatient, please share it with your case management or your social work colleagues, because I think that they can find it really helpful as they're helping patients transition from the hospital setting. Perfect. So let's go to the next slide. Super excited about our next presenters. They are sharing kind of personal experience in an actual case study that happened at Lutheran Medical Center. So team, I will turn it over to you to introduce yourselves and then to give us some insight. Thanks.
Hi, I am Michelle Dudo. I'm the recovery nurse advocate at Lutheran, and I'm not sure if Amy is going to be able to join us. I looked a minute ago and she wasn't on yet. She had another meeting. So we picked this patient because she was pretty complex, and where we think we did some things well, we clearly saw we have a lot of room for improvement. So this patient was, she's a 38-year-old G7P5 with no prenatal care, unstable housing. She was living in her car. She actually presented to us a week prior to coming in active labor, was found unconscious, brought in by 911, severe range pressures, as well as positive for fentanyl and meth. When a plan of care was discussed, she checked out AMA. She came back to us a week later in active labor, unknown gestational age, active substance use disorder using methamphetamine and fentanyl, severe range blood pressures on admission. She was agreeable to care and treatment. So she was started on magnesium sulfate, labetalol, labored, delivered an uncomplicated vaginal delivery. You can see that withdrawal order set that we have was activated on that upon delivery. Her baby did go to the NICU. She had very supportive family, 3 sisters who were by her side and assumed care of the baby. And so she remained on L&D for 24 hours for mag sulfate. She was then transferred to mom baby after delivery. Her blood pressures and withdrawal symptoms continued to be a challenge. We don't have a great process in place for MAT therapy. We have had a few OBs who have said they will try and start Subutex. The patient was requesting methadone or wanting to be discharged because she felt so uncomfortable. The internal medicine consult, that's who we would consult to kind of help support our OBs at this time with MAT therapy initiation. It was not initiated. Our team got a referral, as well as our ARTS team, which is our assessment and referral to treatment team. At that time, our case manager and the ARTS team, after evaluating her, put her on an emergency hold. Unfortunately, West Pines, which is our detox unit, does not take patients on an emergency hold. So when she was obstetrically stable, she was discharged to Jefferson County Mental Health, which is a non-medical detox facility just around the corner from Lutheran. She returned within 3 hours to our emergency department due to elevated pressures, and that is just out of their scope of care there at JCMH. She was transferred to a medical unit where she stayed for 3 days. They continued treatment for withdrawal symptoms and her hypertension. Again, no MAT therapy was initiated. The medical staff did not facilitate visitation of baby in the NICU. And she again was discharged after she was stable on that medical unit to JCMH. So as you can see, our gaps in care are prenatal care for patients with substance use disorder who are not currently seeking treatment and often unhoused. We have a lot of women that come in still actively involved with substance use and have not received care. Really managing blood pressures with patients that are withdrawing and deciphering. I mean, obviously we have the labs that will go with preeclampsia and other things, but we are struggling to see some pretty high pressures in general with withdrawal. We're really struggling with initiation of MAT for patients experiencing that opioid withdrawal. Stigma related to substance use diagnosis interfered with NICU visitation. I actually met with this patient a couple of times, as did my colleague, and the nurses on the medical unit said they were told that the patient wasn't allowed to see her baby because CPS was involved. We tried to provide a little education with that and get people on the same page. I think she did finally get to see her baby before she discharged to JCMH. And then just knowing what treatment centers we can transfer these patients to that have not only MAT prescribing capabilities, but that will also take a patient on an emergency or involuntary hold.
Thanks, Michelle. That's super complicated. I think it really highlights the point that treating patients who are experiencing substance use during the perinatal period is this really fine balance of treating medical care and behavioral health care together. And I can see, I like that you highlighted the point that one of the challenges you face is that some of the obstetric care providers either weren't equipped or weren't comfortable to initiate MAT treatment. And so I think, having obstetric providers become more comfortable to do that can sometimes bridge that gap, particularly when the coordination of care, inpatient even, is super challenging to have both of those types of treatment can be done at the same time. I want to open the floor if anyone has questions about this case study, if you've dealt with a similar case, if you've had these gaps in care and you've been able to address them at your facility.
I have a little bit of a just an ignorant question. Do hospitals unanimously stock both methadone and buprenorphine, or are there some that don't have both of those options or neither?
I'll probably leave it up to the hospitals. If you guys want to put it in the chat, maybe what your facility is, yeah, and if you stock one or both. In my experience, I think most facilities stock both, but I'd love to hear from the people that are here.
I think I just want to say I'm really happy that the bias training is coming up, because I have been witnessing just abuse in these situations where at the end of the day, we can have our opinion about what this person is choosing to do, but we are obligated to give them care, and it's humane care, and that we could be, yes, traditionally, Amber, nurses were the respected profession, but people don't trust nurses right now because nurses are highly abusive, and that's just the culture of the hospital. So I'm just excited that there are the Michelles out there, that Lutheran is a place where I know folks go and get the care. I'm really excited that we're changing this, because even if there are all those gaps were there, even if this person had a NICU visitation, it could have been the thing that gave this person hope and changed everything. So I am just excited that who is on the call today, so that we can kind of shed light on the reality of how people are being treated and why they don't come to care. They would come to care if there was someone who believed in them in that doctor's office or that midwife's office. Even if it was the person at the front desk that didn't give them grief, they would show up, and then it wouldn't feel like the train wreck that everyone in the hospital setting feels that it is. So I'm just glad that we're here talking about how we can make like real changes real fast, so that folks who are experiencing substance abuse will have a person in the system that isn't charting that they need CPS to be involved. I mean, that is another piece. I hope that is, we don't have enough social workers, but when we chart and it is, the charting can get a child taken away, or the charting can help someone get help. And so I just want to, it's not just what we give to the patient, it's also what we write down, because that follows them forever. So I just want to remind folks that even when you're doing your charting, it's important that you be objective and helpful, and not opening this door to more obstacles and barriers moving forward with these folks.
Pia, thank you. You brought up so many good points. I should have been taking notes. I also love, Michelle, that you pointed out that the stigma and the bias that this patient likely experienced on your unit wasn't limited to the labor and delivery staff, that it was also the nursery staff. And I think we extend the invitation to attend the stigma and bias training to all nurses on your unit, whether they're labor and delivery or nursery, because absolutely the way that a mom is made to feel whenever she's interacting with her baby matters. And so thanks for pointing that out. Anybody else?
I think a lot of us in this room can look at this case and just be like, oh my God, this is horrible. We've had a lot of the bias training. We clearly are engaged in changing this, but just remembering, even remembering back to when I worked in the NICU 20 years ago, and I saw babies that were chemically dependent, And it's really hard as a nurse that hasn't had this experience, and really like just to meet people where they are and really encourage them to do this training, because I think nurses go to work to do the right thing and to help people, and they're really seeing this baby as a victim and this mom as a perpetrator, but that's just not how this disease works. And helping be that trajectory of change to help people come around and really understand this disease, and that these drugs are often making choices for these moms. They don't want to be in the thick of their disease. They don't have the support systems they need. And how do we help providers and nurses and caretakers to really understand this? Because I mean, I think I probably 20 years ago had a very different viewpoint than I do now. And not saying that any of this is right. It's horrifying. It makes me want to cry. But at the same time, I think people are not malicious. They're just really ignorant and really needing to be able to meet these birthing folks where they are, and give them the empathy and the help that they need.
Yeah, thanks, Laurel. I don't want to like steal Carly's thunder, because next coaching call next month, we're welcoming Carly back to share more details about the nursing survey that she sort of gave us a little bit of insight in today. It's very important information for those of us who work in healthcare to hear, and it's hard information to hear. But I think sort of lending to what Laurel was saying is that Carly asked the nurses that were surveyed if they had professional experience working in substance use settings, and almost universally they said no. And so this isn't, I think that there's a huge opportunity for us to just educate nurses about substance use, because a lot of the stigma comes from fear, right? Fear that they're going to do the wrong thing, say the wrong thing, harm the mom or the baby in some way with their actions. And so stay tuned next month. I'm super excited for you all to hear more depth for the surveying that Carly is doing. And so come back for that. Anything else?
One quick thing is just that for all of you who do have the ability to distribute this to your staff, we also have many responses from the nurses specifically saying, I've gotten no training on this in my education. I've gotten no on-the-job training. I don't know what to do with these patients. So just so you know that it's not only we know that the nurses need training, but the nurses themselves report by choice. They choose to add this as a comment that they want the training. So the more that we can get this onto the normal everyday labor and delivery unit nurses, that's where we have the ability to make the most change. So I implore you to take what you've heard about here and just start talking about it to people, get them excited. And I think that's really where we can have the most impact.
Thanks, Carly. And thanks, Michelle and Lutheran team, for doing the case study. I will always open the floor for any other teams who have case studies they would ever like to share with our cohort. There's so much value in sharing experiences. So case studies on maybe patient care that went absolutely right. We would love to hear about that. And let's share those wins and learn from that. And maybe like this case study where you can identify where there were gaps in care and where we as a cohort can sort of brainstorm around improvements around that. So you're always welcome to email us. Let us know if you have a case study that you'd like to share. But we'll move on. There is a new document that was released by the Department of Public Health on July 1st that I wanted to bring to your attention. We will email the link to this document out in our follow-up email. But one of their data experts did some excellent surveying over the past few months on how healthcare organizations are gathering and using data around perinatal health. And specifically, they looked at how we're collecting and using data around race, ethnicity, and disability. And that includes incidents of disrespect and collecting the actual stories of patients during their perinatal course. And so generally, this document sort of outlined that there's a lot of gaps in how we're collecting this data. There's much room for improvement for the quality and the amount of data that we're collecting when it comes to race and ethnicity. There's almost no data on disability in the perinatal period that's collected and shared in a really meaningful way. And one step further, there's almost no data that collects sort of the interplay of disability, race, ethnicity, and the perinatal status, right? And this is the data that we use in order to identify disparities and to improve care for the most vulnerable of populations. And so for that reason, I think it's a really important document for you to lay eyes on. I wanted to just take a minute and bring on the next slide just a couple of the sort of more important points here that the Department of Public Health wanted us to know, is that there's variation in race ethnicity data collection. Again, disability data very rarely collected in any meaningful way, either in the EHR or even just in sort of subjective data gathering from healthcare providers. That stories from pregnant and postpartum people are rarely collected. Sometimes they're collected in patient satisfaction surveys, but those types of surveys aren't shared publicly. Typically, those are for internal improvements for a facility, and therefore there's no value to sort of the larger perinatal community from learning from those stories. They clearly identified that staff training on stigma, bias, and racism is lacking. And that many facilities offer some sort of training, but that many of the staff who participate in those trainings find them to be not useful because either they're not geared specifically towards the perinatal population, which includes sort of this extra layer of stigma and bias that comes with substance use, and because they were recorded videos, not interactive, not multimodal, and therefore sort of easily entered into your brain and then lost within the same day, right? And so I'm excited to read this because these are some of the things that we are trying to directly address with our program here. And if we go to the next slide, I wanted to remind you all that we, as part of this program, collect race and ethnicity data. You are familiar with our data collection form, all of the champions that are on this call today, that we collect race and ethnicity data both on a unit level, so for the entire birth admission volume for a quarter, we know the race ethnicity breakdown, and that's what you guys are giving us from your electronic health records. And then for every patient who screens positive, these are the patient level forms that we are encouraging your staff to use as a clinical care checklist. And on it, we also want to know specifically of the patients who are screening positive, what is their race and ethnicity? It's on us that this does not include disability. So we are also learning and improving as we get more data. And we are learning sort of what the shortcomings are for public health and how we're using data. But we have done improvements about the ways that we're collecting race and ethnicity data. And for those of you who have been around a while, you might remember that initially we collected race and ethnicity as one category rather than two separate categories. And we realized that wasn't valuable data for us. And that was for a few reasons. One, because it didn't then correlate with the data that's used statewide, that's in alignment with vital statistics and birth certificate records. So we are constantly improving the ways in which we're trying to collect the data from you, but this is a partnership. And in that partnership, we really need you guys to prioritize on your unit that the data on race and ethnicity for your patients is both in your patient's EHR and then also included on your patient level data collection forms. We will acknowledge for you that it's often not the nurses on your unit who are inputting this data into your EHR, that it's often your admission team. And sometimes the quality improvement needs to happen on a unit that's not yours or in a department that's not owned by labor and delivery. And if that is the case for your facility, if you're finding that you're consistently having trouble either getting race and ethnicity data in your EHR and or getting accurate race and ethnicity data that you believe is patient reported race and ethnicity data, we would love to dialogue with you about how we can partner to help that improvement piece in your hospital admission or whoever is initiating the EHR record for the birth admission, how it is that we can make improvements on that side of things. So we'll go to the next slide. And I just wanted to drive this point home here in our last couple of minutes that why is this document important and why do I think you should lay eyes on it? One is because we are part of the process here of collecting perinatal race and ethnicity data and doing it in a meaningful way that we can draw conclusions about how to improve care. You might remember Gretchen, she just told us how we're doing with that, and there's improvements that need to be done. And so reach out to us if you need help with those improvements. There are best practice documents that are available for us on how it is that race, ethnicity, and language data data should be collected in sort of an ideal situation. And we can always rely back on those best practice documents when we're working with our EHR or our admission team on how they're collecting and inputting that data. Nurses at our participating hospitals, and I can't stress this enough, that the survey data that Carly is sharing with us is from hospitals that participate in our program specifically. This isn't statewide. These are hospitals who have dedicated time and effort to quality improvement around perinatal substance use. And this is the stigma and bias that we're acknowledging happens with the nurses at those hospitals. There is a need, and we're hoping to fill it. We are offering these trainings in October. We do not have the power to make them mandatory, but we really invite you as leaders and champions of the programs at your hospital to find ways that you can really make this an important piece of the nurse training on your unit. Reward the nurses in some way for attending, acknowledge the nurses who are participating, whatever it takes for you to get participation in these stigma and bias trainings, we support you in it. And if you have a great idea for how to do that, share it so our other facilities can benefit from that as well. I'm going to move on for the sake of time here, and just sort of, actually move on again, share kind of what's coming up. And we have a couple of important announcements. We needed to change the time, the dates of our September and our October coaching call. You guys know that we are a long-standing date on your calendar for the third Thursday or the second Thursday, whatever, the Thursday of the month that we do this. We had to move it because of scheduling difficulties to the Wednesday before for the next couple of months. And so we wanted to give you plenty of notice for that. You might have noticed that the calendar invites have changed. This is why. Same coaching call, same content, same people, just a day earlier. And so if you can go ahead and modify your calendars, we would welcome you to do that. Next month, we are going a little bit deeper on data analysis, and we really want to give you sort of the tools and the knowledge for how to interpret your own data. And specifically when you're looking at run charts, which is a lot of the way that we report data back to your teams, what are you looking at? What are you looking for improvement? And how can you interpret those for your teams in order to share your data more meaningfully? We are also anticipating having a speaker from the Maternal Mortality Review Committee in order to share the most recent data that's coming from them about mortality in Colorado. Really looking forward to what that speaker has to say. In October, then, we're going to talk about sustainability and how it is that we can cement the changes and the positive impacts that we've made for perinatal substance use into everyday care on your unit. And then we're also hoping to have a speaker on suicide prevention. In this program, we speak a lot about perinatal substance use, but we know that the number one indication for maternal mortality in Colorado is actually suicide. And so we cannot overlook that. And so really looking forward to the suicide training. Next slide, I think that might be about it. We just have like 2 minutes left maybe, but we would be happy to open up the floor. Other questions, concerns, suggestions, the floor is yours.
I just want to thank everybody for being here and doing the work. It's so important. And it's nice to see that there's such a big group of us, and I know it will grow so that we can make changes for our families in Colorado.
I just had 2 comments, and one is I'm not sure that I see much on how people are getting the data collection done. I'd love some ideas on that. I'm going to look into it at Denver Health too. I've got an email cooking. The other thing is with the bias training, you know, one of the most painful things I think in clinical practice is to be an observer of biased comments and behaviors and take a step to call that person in, not calling out, but calling them in and talking about it. Something that's very difficult for me. Not that I'm afraid to say anything, but when I say something, I know that I always come off as kind of condescending. It's hard for me I get a little emotional about what I'm hearing. It's really hard for me to point out, say when we have a team discussion every morning on Mom Baby and a comment is made. I don't want to shame anybody. And so is that part of the bias training, or can it be to help us have conversations with our colleagues that are, I think, that help to promote thinking about things in a different way, behaving differently, but that don't provoke shame or defensiveness. And, you know, because then people just will just turn their ears off. So it's hard for us to hear about, you know, all the mistakes that we've made over the years too. And it takes a lot of practice to hear hard stuff without being defensive about it. It takes
completely
practice.
Right.
I Googled how to do that once.
No, you're completely right.
So
and that's
can this be part of the training?
Yes. Yeah, that's actually the best way that we can get it. So we can get it so individual nurses are able to recognize their own behavior and they can make changes. But the way that we get that to be a culture change on the unit is giving them the comfortability and the ability and the verbiage to be able to correct their peers politely and understandably. So like, just a very short example, I was in clinic recently and I heard one of the nurses refer to her patient as an addict. And another one of the nurses says, yeah, she has a substance use disorder. And the conversation continued. And it was the easiest, quickest interruption. And you could tell that one nurse was like, oh, maybe I can change my verbiage going forward. It doesn't have to be a huge thing. But it's just being able to stop it in the moment. So that is actually one of our big takeaways that we're going to try to include.
Good. Yeah, perfect.
Yeah.
Thank you.
Ellen, if you come to our training, I hope that you share that. It was so real, right? The way that you shared that it's really challenging and you get emotional when it happens, right? And I think the closer that I get to this work, the more of a stickler I am about person-first language and trauma-informed language. And it's really hard for me to catch myself sometimes and like how to make those corrections and model that in a way that feels positive and not punitive. So we're really trying to address that in the training, and I'm glad you brought it up.
Thank you.
All right, I know that we're at time. Sydney dropped the evaluation form in the chat. If you guys wouldn't mind filling it out quickly before you head out. We really look forward to seeing you next month at the coaching call. We're always happy to schedule one-on-ones between now and then about any of the questions that were brought up in the chat. Any data needs, Gretchen is available to you and very happy to talk data. Otherwise, thanks all for attending.
Thanks, everyone. Have a good afternoon.